This week they've been laying to rest Neela, Dr. Kobe Tetechu III. We wish him well on his journey to eternal rest and peace. And I know he'll find solace under the wings of the Almighty. Let me also wish Dr. Michael McCarthy and his wife a happy 23rd anniversary, I believe. Let's take these from the daughters and come back. I love this to bits. Wherever you are, whatever you're going through, you can't go wrong with the daughters. Oh, sadly, I've got to cut into this. Start the business of today. Oh, Ultimate Health on Joy 99.7 FM. And last week we set off to learn why we're getting progressively younger and younger patients, clients with kidney disease. I'm glad to have in the studio once again with me Dr. Vincent Boyema. He's a consultant nephrologist, head of the nephrology unit of the Kolebu Teaching Hospital. He's also with the University of Ghana Medical School. And he's here, kind courtesy of our extended series celebrating and marking the 60th anniversary of the University of Ghana Medical School. We set off last week to learn what the kidney was, what it does, and then how it becomes compromised. We'll do a quick wrap-up of that and then go into other issues like the staging of kidney disease, treatment and management. You may recall last week he said there is no cure once you get to the chronic kidney disease stage. Doc, you're most welcome.
Thank you, Doc.
Right, and I hope you've had a good week.
Yes, of course, it's always a stressful week for every doctor, because of the busy nature of the job.
Right.
So a good week is really as stressful as you already know.
Right. So good means stress, but it also means you are touching and saving lives.
Absolutely.
Right. Okay. We're so glad and honored to have you again. Last week we learned what the kidneys were. We have two of them, about the size of a human fist, average fist, right? Bean shaped, and they serve to filter the blood, rid it of all the waste products, byproducts. They also balance many hormones. They are responsible for the production of red cells, and they also balance sodium and other things, right?
Yeah.
And then we learned that under certain circumstances, their function may become compromised. So if you can take it from there and just give us a quick recap, and then we get to the point of kidney disease.
Thank you, Dr. Nortey Dua, and thank you once again for inviting me. And very good afternoon to your listeners. We have been talking about kidney disease from last week, and we talked about acute and chronic kidney disease.
Right.
We said acute is usually reversible and is due to short-term illnesses. Once the underlying cause is treated, usually would reverse. But we also said that the acute is a risk factor for a future chronic kidney disease.
Right.
And then we also talked about chronic kidney disease, which we said is one that is insidious and progresses slowly over time, at least 3 months or more.
Right.
And will surely progress to the end, and is usually not reversible.
Okay.
We talked about some of the causes to be diabetes, high blood pressure, family history of kidney disease. In terms of polycystic kidney disease, we talked about inflammation in the kidneys. We talked about infections like hepatitis B, hepatitis C, HIV. We talked about autoimmune diseases.
Right.
We talked also about exposures in the environment, and we mentioned the habitual use of NSAIDs, example Brufen, diclofenac, and we mentioned the use of herbal medication as possible.
Okay.
Hazardous exposures to the kidneys as well.
Right. Okay. So if you just joined us, it's about 15 minutes past the hour of 2 on Joy 99.7 FM. My name is Nortey by nature. I'm in the studio with Dr. Vincent Boyema. He's a consultant nephrologist. He specializes in kidney disease and related conditions. He's with the Kolebu Teaching Hospital and also with the University of Ghana Medical School, which is celebrating 60 years of quality education, quality medical education. Congratulations to the school, our school. And if you have any questions, concerns from last week, or even new questions for this week, my WhatsApp is 055 11 11 997. We're live on Facebook and YouTube, and shortly we'll activate the phone line so you can ask your questions directly. So we learned about compromised kidney function, and we understood that if you have compromised kidney function for 3 or more months, then we could be looking at a diagnosis of chronic kidney disease.
Yes.
Whereas the acute one was short-term, likely to kidney injury or infection, and is reversible. Yeah. So let's stick to the chronic kidney disease.
Right.
One of the things we spelled out and emphasized last week was that we're getting younger and younger patients. And some of the factors were the fact that there are several people with undiagnosed or uncontrolled diabetes or hypertension, which are serious risk factors for kidney disease, and then other conditions, and then our use of medications, herbal preparations, and many other things apart from family history.
Right.
So these are the factors that are accounting for younger persons with kidney disease.
Yes, so when you travel outside the shores of Africa, perhaps Ghana,
right?
We said people who are afflicted by kidney disease are usually more than 60 years of age, those on dialysis. They equally have these risk factors of diabetes and hypertension.
Okay.
And I think one of the reasons why maybe our young folks are being affected is, number one, it's not detected very early.
Okay.
Maybe the diabetes is not diagnosed early. Hypertension is not diagnosed early and treated and controlled on time to delay progression or even prevent the development of the disease.
Okay.
We talked about other exposures in our environment, peculiar to our environment, which may be also reasons why our young folks are being affected or afflicted by this disease. And we talked about genetic predisposition and also highlighted the possible interaction between these genes and environmental factors which may be at play, and maybe the reason why our people may be at higher risk of developing this kidney disease at younger ages compared to other racial groups.
Okay, right. And a lot of research and data has been collected which confirms, we talked about some of the researches last week, Osafo et al., the one with
Tano et al.,
Tano, Plandrul, and so on and so forth. And then we realized that in persons with hypertension and diabetes, whether diagnosed, identified or not, this population have a higher prevalence of kidney complications or kidney disease.
Right.
Is that right?
Yes, that's right.
Okay. Right. I've got this from Sandra. It says, good afternoon. I want to know the causes of kidney disease and the symptoms. Well, we've dealt with the causes and the risk factors that may predispose you to kidney disease. We did mentioned last week that in the early stages you may not see symptoms, but then we also describe some possible symptoms.
Yeah. So maybe this is the when to talk about the staging so people can put it into context.
Okay.
So kidney disease is staged from 1, 2, 3, 4 up to 5 based on the kidney function. And the kidney function is determined in terms of what we call glomerular filtration rate.
Okay.
And if it's more than 90, stage 1, if it's between 60 to 90, stage 2.
Okay.
Now, stage
Doc,
1 and
with
2,
your permission, I'd like to filter this slowly. All right. The kidney essentially is a filter.
Yes.
Right? It cleans the blood.
Right.
So you're saying that based on how effectively or efficiently it's able to do this, we can give you stages of your kidney disease.
Yes.
All right. So you started with a stage 1
or more than 90 in terms of filtering the blood, filtering about 90 mils of blood per minute.
Okay.
That is more than 90 mils of blood per minute being filtered by the kidney. That's like stage 1.
Okay.
Stage
so again,
2.
let me just come in for my listeners, right? Listeners, pardon me. I'm making sure you all understand. So you are talking not only of the filtration of the blood, but the rate at which the kidney
filters the blood per minute.
Right.
Yes.
So how much blood it can filter per minute. So it's a rate.
That's the rate. Yes.
Right. It's not just the fact that it's filtering.
Exactly.
It must do it at a certain rate.
Yes.
Okay, great.
So and then between 60 to 90 is also a stage 2. But stage 1 and 2 will need additional markers of kidney damage to be classified so.
Okay.
So they will need, for instance, markers of kidney damage like protein or blood in the urine before they can be classified as stage 1 or 2.
Okay.
Otherwise, with no blood or protein, you can't really refer to stage 1 or 2 using these figures on their own.
Okay.
Now,
Doc, listeners, if you've just joined us, this is Joy 99.7 FM. The program is Ultimate Health, your ultimate guide to healthy living. This and every Sunday, 2:05, we come alive with all the precise, up-to-date, unassailable health information. We're doing just that now with Dr. Vincent Boyma. We're talking about kidney disease, and we are emphasizing on young but failing kidneys. Though talking comprehensively about kidney disease. If you have any questions, concerns, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube, and shortly we will activate the phone lines as well, so you can ask the questions yourself. Now, Doc, you were talking about additional. So you can use the GFR or the filtration rate.
And you can use the protein excretion in the urine.
Right. So what I wanted you to clarify for my listeners is, are we saying that anytime you see blood in your urine, I mean, as a layperson, right? Of course, this is reason for worry, right? But are we saying that if you have blood in your urine, then it is possible that there could be a linkage to kidney function?
It could be linkage to kidney disease.
Right.
So, in not necessarily the function, it could be linkage to kidney disease.
Okay.
We define the function in terms of the GFR, which is the filtration rate.
Right.
All right. So, a protein in the urine could be an early sign of a kidney dysfunction.
Okay.
So that is why it is important for us to really put this in context. So you don't take more than 90 stage 1 without really looking for these markers of kidney damage.
Right.
Now, kidney function below 60 below 60, irrespective of whether there's protein or blood, is still chronic kidney disease.
Right.
Once you go beyond stage 1 and 2, you don't need the markers of kidney damage anymore. You can still classify
So
them.
you've given us a minimum, a threshold there.
Exactly.
Where you've crossed over now into
Yes.
chronic kidney disease.
Yes. So
Right.
between 30 to 60, it's stage 3
Okay.
kidney disease, irrespective of whether you have protein or blood in the urine.
Okay.
Now between 15 to 30 is stage 4.
Stage 4.
Yes, and less than 15 is stage 5.
Okay.
That is the end stage. So less than 15 is more or less the kidney failure that we refer to.
Okay.
Yes.
Right. So the higher the stage number, then the worse off you are in terms of kidney function, right?
So
the disease is progressing.
The less the GFR, which is the less the number I'm using right now, the worse the function.
Yes, but I want the listeners to also understand you started from 1.
Yes, 1
so
is
the lower the stage,
the lower the stage,
better your kidney function, though there's still a disease of.
Well, so in terms of the number 1, 2,
Right.
3, yes,
Yes.
that's
Okay. All right.
Yes.
Now, Doc, let me ask you this interestingly. I mean, you are qualified to make these determinations and distinctions and indeed a diagnosis.
Yes.
Should somebody go to a lab, right, and come out with a GFR and and suddenly start saying or thinking or being told by anybody other than a nephrologist that they have kidney disease?
So I think that's why we said last week that just a once-off test telling you that you have a kidney function of, say, 60 or 40 is not enough. You need a pattern over the last 3 months to be able to tell whether this has been going on for this period or not. In addition to maybe a scan of the kidneys to see the appearance of the kidney, the size of the kidney, or perhaps also you need to, if where possible, do histology, etc., to tell whether there are chronic signs in a kidney or not. So just one test is not enough to diagnose chronic kidney disease without knowing what the kidney function had been before in the past, or without having an idea of what the kidney looks like on imaging.
Okay, great stuff. Please, do blood tests alone, or are blood tests alone enough to know whether your kidney is functioning well or not? You just heard what Doc said, right? This is from Daniel in Equipim. Where's my mouse? Okay, got the mouse. Right. This one says, good afternoon, Nortey. Please ask for me, if a person hasn't been affected by diabetes and any heart-related issues, but straightforward gets hepatitis B, can that also be termed as chronic? This is Ajiman Joseph in Committee 9, right? You don't have diabetes or any heart-related issues, but you do get Hep B, right? And then he jumps to chronic. I don't know whether you can make...
I think it's a bit confusing what he's referring to. But we don't need diabetes, hypertension to get hepatitis B. Hepatitis B is an infection that you can acquire on its own, independent of these other non-communicable diseases that is mentioned. Hepatitis B can be acute or chronic. Again, that one you need to see a doctor to put it in perspective for you. If it's acute hepatitis B, you actually be very ill and probably end up in the hospital where it will be diagnosed earlier and treated. For your chronic hepatitis B, you probably may pick it up incidentally through many tests that you may be doing for other stuff, and then you need to see doctors to interpret it for you in the context to say this is chronic hepatitis B. However, we know hepatitis B can cause kidney disease. And therefore, it can predispose you to what we call nephrotic syndrome, where you lose a lot of protein in the urine, gets swollen up. But this kind of nephrotic syndrome is actually a type, this kind of hepatitis B related kidney disease is actually a type, it induces a type of inflammation in the kidney that may progress over time as well to chronic kidney disease, end stage kidney disease, etc.
Okay, so I hope that sorts you out, Tajiman Joseph. I have another question. Let me see quickly. What does it say? Can one do the test without a doctor's prescription?
So it is good for everybody to really seek to screen or test for kidney disease, just like we really staged kidney disease right now in the early stages 1, 2, 3, for instance. You are healthy like everybody else walking on the street with no symptoms. You feel well, and therefore you think you don't have to go to the hospital. But like we said last week, the disease is largely silent, and therefore you need to test. So what test would you do? Simple things that can be done. It's easy. It's not expensive like you think. So you can go to the polyclinic or hospital and then do test for protein in your urine.
Okay.
That could be a start. Like we said, protein in the urine could be an early sign of kidney damage.
Okay.
And you could also do the kidney function test, the GFR that we talked about right now. So they'll measure your creatinine and use it to estimate your GFR.
Right.
In addition, it's very important to also look for your risk of kidney disease.
Okay.
So check your blood pressure, check your blood sugar. They are all very important things to do when you're screening for the risk of kidney disease and also for the kidney disease itself.
All right, great stuff. Dr. Vincent Boima is with the medical school. He heads the Kolebu Teaching Hospital's nephrology unit. He is an alumni of the University of Ghana Medical School, the 2002 year group. Yep. He finished. He went on for further studies in South Africa, came back. Yes, no brain drain. Came back and he's been doing a yeoman's job alongside others. He tells us they are training more nephrologists. They still, for the time being, do go outside to specialize, but we're getting closer and closer to localized training. Am I right, Doc?
Yes.
Okay, great. If you have any questions, concerns, experiences for Dr. Boima to clarify or answer your questions, 055 11 11 997. That's the WhatsApp number, and we're live on Facebook and YouTube. 229. Shortly, I will activate those phone lines. Linda Inosu, you're most welcome. Hope you're doing great. I would like to know if there's any natural food that cleanses the kidney. Good afternoon, and keep up the good work. Any natural food that can keep us away from you, doctor? I mean, keep our kidney in good tip-top shape.
So I think I'll look at this question more in the direction of healthy eating that we all know of, that prevents non-communicable diseases. So eat healthy, so more fruits, more vegetables in your food, and also decrease the carbohydrate intake, decrease the sugary food intake, decrease your salt intake, exercise, lose weight, stop smoking. These are very healthy. It's a healthy way of life, healthy lifestyle that can really decrease your risk of developing kidney disease and other non-communicable diseases like diabetes, hypertension, obesity, which increase your risk of developing kidney disease.
Great advice. Please, I pee not less than 15 times a day. What could be the problem?
So you pee not less than 15 times a day.
Well, not me. This is, I think. Well, there's no name. Okay, but
I'm just
right. I know.
It's quite vague to think about pee. It depends on the volume of urine the person is producing.
Okay.
So if you are producing large volumes of urine, say more than 3 liters per day, that's large amount of urine.
Okay.
That also could be due to some kinds of conditions that may need to be investigated. But if the volume is within acceptable limits, say between a liter to less than 3 liters, probably that's okay. If you are peeing more frequently, that also may be a sign of disease. For instance, you wake up very frequently in the night to pee. That may be also an early sign of kidney disease, which also needs to be investigated. Peeing very frequently could also come from those who have prostate problems, for instance, or have problems with your urinary bladder, for instance, etc. So again, if it's frequency of micturition or urination, that also needs to be investigated.
All right. Great. You hear all the big words here, but we break them down. You heard micturition, right? Production of urine, right?
Yes.
Wow. All right. Ultimate Health on Joy 99.7 FM, 31 minutes past the hour of 2. We're doing great work and we are learning and growing. You can join us when I activate the phone lines in a sec. Let me see what else I can read. I can see Dede in Maryland typing. Bonjour. So at what stage or range or threshold does one go on dialysis? Yeah, we're getting there. We're not there yet. And then kidney transplant. Dede wants to move to that stage of management. We'll get there in a sec, Dede. Thanks for tuning in every Sunday. And she's still typing, so I'll go back there and have a look in a sec. Good afternoon, Nortey and team. May I know if the blood in the urine is visible to the naked eye, as in the case of bilharzia? If yes, what is the relationship between bilharzia and kidney disease under discussion? This is Teacher Saddam in Bato.
So thank you very much. Bilharzia, you can have what you call macroscopic hematuria, which is visible in the urine. You can see it. So usually that's the initial stage where maybe you will swim in a river body where you develop bilharzia. You can pee blood in your urine, and in fact, those in the same community who swim in the same water body will be same peeing blood all around. Schistosomiasis, exactly. So bilharzia can lead to kidney disease. It can cause obstruction to urine flow, so blockage in the urinary tract, and therefore can cause kidney disease. It can induce inflammation in the kidneys itself, the glomerulonephritis we talked about, and can cause that kind of kidney disease as well, which can cause the whole body to be swollen and can actually progress if not handled or treated. So yes, bilharzia can cause kidney disease.
Great stuff. I remember years back, I think 91 or 92, we did some work in the Wager Basin. Some of those settlements, Denshira, Ashalaja, Hobo, Tokuse, and other things. The kids they close school and they play in the water, right? And we had a high prevalence of these things. This one says, good morning, Kojo. I think I need to scroll down. It says, good afternoon, please. So what is normal kidney rate per unit? Kweku from Adenta. I don't know whether he's talking on normal urination or production of urine.
Probably talking about GFR, I think.
Right. Okay.
Probably it could be between 60 to 120, but it could be more than that. It varies.
Okay.
So, like I said earlier, on anything less between that, you need additional markers of kidney damage to really say that there is a damage occurring in the kidney. Below 60, irrespective of whether you have these markers of kidney damage or not, you could still be classified as having chronic kidney disease.
34 minutes past the hour of 2. We're still in our extended celebration of the University of Ghana Medical School 60th anniversary, celebrating 60 years of quality medical education, the role of technology. Last week, Doc outlined some of the advancements that make it easier to pinpoint conclusively the diagnosis of kidney disease. So we're still extending that. I've got this one. I think I read that about visibility of the blood. One of the things I wanted to ask, you encouraged a listener, Linda, that it's okay to go into a lab and screen for your numbers, know your blood sugar and all that. Where you've done this screening, albeit on your own, should it progress to seeing a doctor, a specialist? You know, should you just handle this and say, well, these look like because the printout gives you the ranges. So many people feel they can read this in the absence of other, should I say, factors or symptoms or presentations. At what point should you take this screening further?
So I think that if you do the kidney function test and the creatinine on the lab says it's within normal limits, maybe the GFR is giving say within normal limits, probably, and you don't have a risk factor of kidney disease like hypertension or diabetes, there may not be any need for you to see the doctor. But if you do have risk factors, of course, the risk factors have to be controlled and kept in check so you do not develop kidney disease. Now, if you have a test that shows that you have an abnormal GFR or abnormal creatinine or elevated creatinine, you have to see a doctor for interpretation. So that they tell you, oh, this would correct, or this is nothing to worry about, etc. You need to hear it from the experts who understand it and can explain it to you. If you do the urine test and there is no protein, there's no blood, there's no cause for alarm. But if you do see these things, then you need an explanation from somebody who can explain these things to you for you to understand.
You may need somebody well qualified and positioned to explain these things and probably also request further tests if required, right? So in your hands, it may be redundant and you may be sitting on something that needs further verification. Great. Many of my listeners are typing. We'll wait for those. Let me activate the phone line 0302 216 541. Ultimate Health on Joy 99.7 FM. Last week, we looked at the prevalence and it hovered around 13% or so, 13.5, looking at the studies and looking at various populations. In some of the populations, like persons with diabetes or hypertension, the prevalence was higher, right? And I'm glad I'm getting a lot of interest online. I hope we'll get that when the phone lines are active as well. 0302 216 541. I'm seeing something about frothy urine, right? Let me see. Wow, as soon as I click, then it shifts. What about foamy pee? Is it a sign or a symptom of kidney disease where your urine is foamy? 2, is it truth or myth that when one pees on the ground in the bush and uncircle the pee, the one has kidney disease? I thought it was more related to diabetes.
Yes,
but let's
absolutely.
reason that the pee is sugary. Dede is asking this.
So I think the pee attracting ants is probably more that there's probably something like glucose in the urine.
Okay.
So probably that related more to diabetes, not kidney disease per se. Now, a frothy or foamy urine is possibly a sign that there's protein in the urine. So a frothy or foamy urine is possibly a sign there is protein in the urine. So you need to test to see if you have protein in the urine or not.
Okay. Great stuff. 38 minutes past the hour of 2. The phone lines are active. This one says, good afternoon. Please ask Dr. Boima, how many years does it take to specialize in nephrology if you're a general doctor? I am Kennedy and I'm a medical student watching you from Russia. Kennedy wants to know. He wants to specialize.
Yes. Once you finish medical school, you would have to write exams to enter a residency program. The residency program takes at least roughly 3 years. And then after that, you need extra 2 years to become a nephrologist. I also have noticed that it varies from college to college and based on the program they have. So some mostly all over the world is about 2 years for a nephrology program after residency. Some may have it at 3 years as well. So roughly residency 3 years plus nephrology fellowship 2 years. That's about 5 years after medical school.
All right. To specialize. All right. I almost asked you a question about Russia, but let's leave that for now. Right. Please, is it true that sickling positive, all right, you wrote suckling, positive persons may eventually suffer kidney disease or heart disease? So sickle cell and its relationship to kidney disease.
Yes, so sickle cell disease itself, which probably is the genotype with SS or HC or the other variants, increases your risk of developing kidney disease because they can cause kidney disease, which we refer to as sickle cell nephropathy. And again, it can cause nephrotic syndrome, loss of protein in the urine, which causes your body to be swollen. It can progress to kidney failure and end-stage kidney disease as well. The other types, like sickle cell trait, the AS genotypes, have various types of kidney abnormalities, which may not necessarily result in kidney failure per se. There have been researches here and there trying to link it, but they've all not been conclusive. So they can have blood in the urine. They can have a lowered ability to concentrate urine. It causes them to produce a lot of urine, etc. These are some of the things that they can suffer, but they are risk. I'm talking about traits now. They are risk of development of kidney disease has not been conclusive from the studies so far.
Great. 40 minutes past the hour of 2. We're going to zoom into when do you need or when is dialysis indicated and what exactly is dialysis, right? When do we get there? And then what about transplant as well? Let me read a couple more. Please ask doctor if you can have oil in your urine. This is from Kafui in Ashiye. Let me just read a couple more. Jump. Okay, please ask for me again. Does one have to do a series of tests to know if he or she is having chronic hepatitis? There are tests for hepatitis, or symptoms will speak to the person. Ajiman Joseph, there are tests, conclusive tests. I don't know why people listen to radio and think you can solve everything yourself. Then Doc wouldn't have gone to South Africa to train, and other doctors and specialists wouldn't have done so. And this is dangerous and risky. That's why I'm hitting on that. Doc, anything?
Don't wait for symptoms. There are tests you can do, just like Dr. Nortey Dua is saying. Go out there and let them do all the tests for you to be sure whether you do have chronic hepatitis infection or not, so they can use whatever protocol they have to initiate treatment for you as early as possible. That's important. When you wait for symptoms to develop, it may be too late for you.
By the time you see the symptoms, please, it's far gone. Doc, if your urine cytology test says malignant, do you still have to worry if you have plus blood in your urine anytime there's a test?
Yes. So if you have blood in the urine, there are a number of causes, from malignancy to stones to intrinsic kidney diseases to etc. So, for instance, one of the things they do when you have blood in the urine is urine cytology. And the cytology, if it comes by saying there are malignant cells in the urine, it presupposes that possibly the cause of that blood in the urine is a malignant tumor, which has to be investigated a bit further through imaging, through biopsy, to find out if indeed the person has malignancy or not.
All right, okay. Great. Can kidney disease cause frequent or consistent low blood count?
Yes, so we talked about this last week, that the kidney produces a hormone called erythropoietin. This erythropoietin helps to produce your red blood cells, which is your blood literally. And therefore, if your kidney is not working, you are unable to produce this erythropoietin in sufficient amount that would help to produce your blood. So definitely in kidney disease, you would have a low blood count and your hemoglobin is going to drop.
Doc, you're not going to believe this, but I've got this from, I think it's Isaac Laye. Good afternoon. Could Doc please interpret this result for me? And I have his lab results. The PDF waiting for me to download. We try to discourage this, Isaac, for good reason. We don't have any problem or challenge directing you to the appropriate place, right? Radio is to educate, transform, inform, but diagnosis is a very serious...
Your medical condition is confidential.
Right.
You don't have to put it out there in the media. Right. So I think you should see a specialist and then confidentially have your information interpreted to you.
Isaac, I'll try and hook up with you after the show and see, right? Yes. But we mustn't encourage the wrong things, right? Yeah. Doc, we're running out of time, but so at what stage and what is the management? Now we've talked about stages, we've understood the disease or the condition. Right. What is the management and when does dialysis come in?
So that is why we kept saying that test and be detected early. Management can be instituted to delay progression of the kidney disease. In the early stages, there are measures that are put in place to slow the progression of the kidney disease to end stage. So controlling your blood pressure, controlling your blood sugar, making sure you abstain from things that cause harm to the kidney, like the over-the-counter medications that we mentioned earlier on, healthy eating, losing weight, quitting smoking, decreasing salt intake, are measures that you can put in place to slow progression. There are some drugs that have benefit from the kidney. That if the doctor detects you early and is treating your BP, would choose carefully so that they can control the numbers and also have protection for the kidney. That's really ways in which you can delay progression. Now, if you progress to end stage, where the GFR is less than 15, then you start planning and thinking about what we call kidney replacement therapy. And the kidney replacement therapies are two, literally, dialysis and kidney transplant. Dialysis, there are two: hemodialysis, which is a blood dialysis, and then the peritoneal dialysis, which is literally the water dialysis. And then, of course, the second kidney replacement therapy is the transplant. Between dialysis and transplant, kidney transplant is really the ultimate and the best among the two because of increased lifespan and survival. Quality of life is better. It restores fertility. In the long term, it's probably more cost effective compared to dialysis.
Let me read a couple and come back to the dialysis. My name is Adam Suraka. Doctor, I had blood. I think Adam sent a message last week. I had blood and protein in my urine. The doctor diagnosed me with a UTI and told me it is getting into my kidneys. He gave me antibiotics and said I will be fine. I remember this from last week. The mention of kidney alone is getting me depressed. So he's on antibiotics. He had blood in his urine and protein as well. And it was said to be caused by a urinary tract infection.
So that's possible. So the first thing is to treat the infection first. And then, so usually you do the urinalysis where you can see these things in the urine. And then you do the culture to isolate the organism causing the infection. So you treat it. Once you finish treating it, you repeat the test again to see if you still have the blood and protein in the urine. If after treatment these things persist, then they need to be investigated further
Okay.
for other causes.
So, Adam Suraka, yours could possibly be an acute kidney injury
An acute. So due
to
infection, which if treated,
right.
In fact, the infection could be the cause of the blood
right.
itself. The inflammatory markers in the urine
right.
are proteinaceous substances themselves,
okay.
really. So that's why if this thing clears, perhaps all these things may disappear in the urine. Really.
Okay. Adams, I hope you understand. So what it means is that if your urinary tract infection is treated and cleared, the hope is that the protein and the blood you are seeing may remit or reverse. It will go away, right? And that will also need to be monitored to make sure that there isn't persistent or residual kidney damage, all right? 48 minutes past the hour of 2 on Joy 99.7 FM. Gosh, I'm just remembering that I used to love steak and kidney pie. Now I'm worried. Right, okay. If you have any questions, phone lines are active, 0302 216-541. You can ask Dr. Vincent Boyma the questions yourself. Let me see. I have so many people on WhatsApp. This is from Edith Arthur, North Kanishi. Hi, Eddie. If you have protein in your urine, what are the implications?
So we just talked about it, that there are causes of protein in the urine which needs to be investigated.
Okay.
It could be diseases which causes inflammation in the kidney. It could be diseases which causes changes in the tubules in the kidney itself. Okay. It could be diseases which are producing too much protein that the kidney is unable to absorb back into the body.
Right.
And it could be anything. So it needs to be evaluated to find out what the cause of the protein may be.
Okay.
That's important, yes.
Right. So we need to find out what's causing the protein. But we can say with clarity and be emphatic that there shouldn't be protein in your blood.
Ideally, yes. The kidney, the filter or the sieve is such that the protein shouldn't drop into the urine at all. But if there is this protein in the urine, that means the sieve has a problem.
All right.
Which is the filtration barrier of the glomerulus itself.
Okay.
So that means there's some kind of inflammation or disease going on which opens up these pore spaces,
right,
and then causes protein to be filtered into the urine.
Okay.
Yes.
So it's like when your car, your head gasket is gone and you're now getting smoke from your exhaust and then oil in the exhaust and so on and so forth. We need to find out what is causing that breach, right? Yes. Great. You can call us 0302-216-541. Ultimate Health on Joy 99.7 FM. We're looking at young but failing kidneys, but we're talking comprehensively about kidney disease. Doc, I was reading, and from what I read, is it in a day or I've forgotten the period, but the kidney can filter up to 189 liters of blood. Yes. And is doing this constantly. Yeah. So when a person is on dialysis, we hear that they go 2 times, 3 times a week, and so on and so forth. Is the frequency of dialysis an indication of how compromised the kidney is?
Thank you very much. In fact, the dialysis is nothing compared to your native kidneys. Your native kidneys are way more effective
than that machine.
Than that machine.
But
the 3 times a week is just compatible with life.
Right.
So you do 3 times in a week, and if done well, you can survive and you have a normal life and do anything you want to do.
Okay.
In fact, there are people who have been on dialysis for 5, 10, 15, 20 years right now in this country, and they are still going well with their 3 times a week.
It means they are healthy and their bank balances are healthy.
Some are healthy.
Right.
Those who are doing it very well are healthy.
They
do their normal work. They go to school, etc.
Okay.
And then those who are unable to do it well for one reason or the other, probably are not that well. Let me just put it that way, because of complications or problems that they have.
Okay.
And that's really where the issue is about how well you do it, how well you adhere to dialysis prescriptions, really, that's being given to you.
Okay.
Yes.
Wow. All right. Now, so once you're on dialysis, this is something that must continue for the rest of your life.
So again, we looked at acute and chronic last week. If it's an acute kidney injury, definitely once the kidney recovers, your dialysis will be discontinued.
Okay.
But if it's a chronic kidney disease and you choose dialysis, then it's a long-term treatment, and you're most likely going to be on this for life, or unless you decide and you get a kidney transplant.
I'll come to transplant if I can. Good afternoon. I see oily substances in my urine after urinating in a pail. is that a sign of a disease? This is coffee and cophidia, oily substances.
I'm really not sure about that. We probably need to come to the hospital. Yes, sometimes we call in the nephrotic syndrome. We, lipoid nephrosis, sometimes we refer to it. You can have over fat bodies in your kidney. Whether it appears as oily that you can see on or suspended on the urine, I'm not sure, but we do see this on microscopy where you can see the over fat bodies due to the presence of this lipid or cholesterol in the urine. It's called lipiduria, actually.
Right.
Yes.
Okay.
Yeah.
Right. I got this from Cindy. Cindy, thanks for sharing. She says, my son has urine sugar, but normal blood sugar. Is that possible? That your blood sugar is okay, but your sugar levels in urine?
It's another type. It's another type of kidney the abnormality. It's a tubular function. You know, the kidney tubules absorb various substances back into the body, including glucose. So if that part, which is the proximal part of the tubule, is dysfunction or not working very well and not absorbing these substances back into the body, you can spill off glucose in your urine. So it's more of glucosuria, which is not related to diabetes. Doesn't really cause any problem at all, and shouldn't really be shouldn't really cause any problem. I think it was on this basis that some of the new diabetic agents that we have now were developed, actually. Yes.
Great stuff. 53 minutes past your hour of 2 on Joy 99.7 FM. Ultimate Health is the program. We're talking about young but failing kidneys. We need to look after these vital organs. And like Doc is saying, if you get into the realm or the ranges of chronic kidney disease, there's really no U-turn. We're trying to slow down the progression. And this is why it is critical, essential that it is diagnosed or identified properly and early. Right? If you have a question, you can call us 0302216541. Squeeze it in on WhatsApp. WhatsApp is 055 11 11 997. Doc, let me ask this. We hear of long waiting periods for kidney transplant and so on and so forth. Indeed, very rarely do we hear of it being done here. Do we get to that point here in Ghana? Do we have donors and do we have kidneys, should I say literally on the shelf?
There's no kidney on the shelf for you to go and buy.
All right.
Transplant legislations do frown on buying organs. Or paying for organs or selling organs.
It's illegal.
It's illegal to do that.
Right.
So everybody who is willing to donate a kidney to somebody must be willing to give it free. It is an emotionally motivated act. And you don't have to pay for it or be paid for it. It's illegal to do that. So you must be willing to give out freely. To
Doc, let me just quickly take this caller and then come back to the procedures if I want to donate or if somebody wants to donate. Right. Hello. Good afternoon.
Hello.
Hi.
Good afternoon.
Right. Who am I speaking to?
My name is Adjoa.
Adjoa, where are you calling from?
I'm calling from the Eastern region.
Eastern region. Okay, share with us quickly.
Yes, I want to know at what stage that the person starts showing, bulging stomach and have issues with the bowel and all of that. Most of the time, people who go through that, you realize that they go to the hospital, they have a protruding belly, they may not be able to pass stool and all of that.
Right, I'll find out. Adams Raka, I believe, is on the line, right? Hello, Adams.
Yes, good afternoon, sir.
Good afternoon, Adams. You're welcome. You have another question?
My
Pardon? Oh dear, your line is bad. I'll try and get back to you and then get the details directly. But he's the one who talked about the UTI and the blood and protein.
So talking about the protruding belly, for instance, we talked about your body getting swollen and all that. So when you have kidney disease, you lose protein in the urine, your blood protein level gets low. So the forces that really keep fluid in your blood space.
Okay.
Makes you push fluid into
Right.
other parts of the body, which causes your body to get swollen. So some of this fluid is also pushed into the abdomen.
Okay.
And with time, when you collect fluid in your abdomen, it tends to bloat out or become bigger, and that's one of the ways in which you may find people, for instance, with nephrotic syndrome who are losing protein in the urine present to the hospital. They may come with all kinds of other associated problems of constipation or diarrhea, depending on what is happening.
Okay.
Yes.
Right. Sadly, reminds me of something that happened to my dog, right? Starting getting a protruding belly, and then the vet told me that it was an organ-related issue.
Sure.
Right. I have another. Adams is back on the line. Hello, Adams.
Yes, sir.
Right. Go ahead quickly, please. We're almost out of time.
I've been having pains right above my penis and right into my right scrotum, and it's been hurting. And if I urinate, I see physical blood. Like you see, the urine is red. And I was diagnosed of urinary tract infection, and they said it was going into my kidney. And they gave me some drugs. The pain has gone down, and the urine the color has come back a little. It's now light yellow.
Right, Adams, just quickly, how long have you been on treatment, and have you finished the treatment and gone back?
It's been 2 weeks now.
Right, I doubt if you finished the course, but Doc, anything you want to say?
I think he said the urine has cleared now.
It's clearing, the
with
pain is...
antibiotics,
Right.
so probably he's responding to treatment.
Right.
So I advise him to see his doctor who is treating him for re-evaluation and see if there is any other risk, because he seems to be improving. It seems probably the pain is also gone. So that means that he's probably responded to whatever treatment he was given.
Right.
At this point, yes.
Right.
Maybe he had an infection which may have caused some change in the creatinine or GFR.
Right.
And this should also improve once the infection is well treated.
Okay. Great stuff. We're out of time, but Doc, I was wondering if we could stick this in. If somebody wants to donate, what's the process or procedure?
So like I said, it should be free and emotionally motivated. You shouldn't really come with a mind of being paid.
Right, so
or
strictly altruistic donation.
donation.
Right. Okay.
And the person who is afflicted by kidney can identify donors from the family. So maybe siblings, parents, sometimes your spouse as well. And then also, if beyond this you probably don't have anybody, you could also go to extended family.
Okay.
It doesn't mean that an unrelated person cannot give.
Okay.
In fact, your spouse is unrelated and is given.
Okay.
But so unrelated donation, you have to really go to rigorous scrutiny, and also you need a very strong and established legislation in your country really
Right.
to back all these things.
Okay.
So yes, the person can come to the clinic, and then the doctors will assess him and then make sure that he doesn't have risk factors for kidney disease like diabetes, hypertension.
Okay.
He himself doesn't have kidney disease at all.
Right.
And there's no infection, there's no cancer, there's no heart disease, liver disease, many things that will be done to make
Proper
sure
scrutiny
the
and
person-
testing will
yes,
be done, right?
Medicine to make sure the person is safe and the person is not passing disease to the person he's donating to,
Great.
etc.
All right, Doc. I'm going to try and whiz through this so that we can. We're already on 3:00. Doc, so happy to hear from you. I have microscopic hematuria for the past 20 years. Every year I do a urine culture and ARIA, and I will have plus blood. But under culture, they don't find anything. Occasionally, I do the urine cytology and find no major findings. Last year, my CT scan showed stones which were below 3 centimeters, and my doc said it was very little. This we talked about it last week.
Last week, yes.
Right. So this same person talked about the benign cytology test, but then plus urine. I think
So it could be the stone
Right.
causing it, but the stone is probably not 3 centimeters. It's
Okay.
most likely 3 millimeters.
yeah, last
But
week we
3
corrected that.
centimeters
Yeah.
is a
It's
big stone.
It's big, right.
Yes.
All right. Many thanks, Dr. Vincent Boima, consultant nephrologist with the University of Ghana Medical School, head of the nephrology unit, Kolebu Teaching Hospital. Thanks for further education. Maybe we can now all say we have a master's level. But thank you so much, and thank you so much to the University of Ghana Medical School for lending us you to us for another hour. we're most grateful. And very quickly, I'll run through some of the sponsors for this 60th anniversary. The alumni: Ghana Gas, Accra College of Medicine, Family Health Medical College, National Health Insurance Authority, Enterprise Group of Companies, Sonotech Medical Center, MDS Lancet, Quest Medical Imaging, Medifem Hospital, Supreme Specialist Scan, Promasidor, Nestle, Akai House Clinic, GTV, City TV, and of course Multimedia Ghana. Many thanks once again to the medical school and to you, Dr. Boima. I go over to my brother Bile for Sunday Rhythms. Stick and stay on Joy 99.7 FM. Don't go nowhere. My name is Nortey by nature. I'm out.